Melioidosis occurs in tropical areas, particularly Southeast Asia and Northern Australia, but has been increasingly reported in other tropical regions. Melioidosis is regarded as a disease of mainly Northern Australian population with poor general health and high incidence of comorbidities known to predispose of the infection. Northern Australia has an expanding agriculture and mining industry, which has potential to increase numbers of infection exposed to soil, surface water, and aerosols, which contain Burkholderia pseudomallii. Melioidosis can develop within 3 weeks of a person being exposed to bacteria, but in some cases, illness may not occur until several months or years after the initial infection. Symptoms can include fever, weight loss, stomach or chest pain caused by mild bronchitis and/or severe pneumonia and/or weakness in joints and muscles. Acquisitions of melioidosis must often occurs through incorporation with compromised skin integrity, increasing the risk of developing the disease. Localized infections may present with pain, swelling, skin infection, ulceration, abscess formation. The transmission of melioidosis through the skin into the blood results in chronic melioidosis and as a result affects the heart, liver, kidneys, joints, and eyes. Type 2 diabetes is the most significant risk factor of developing the infection. It occurs in 40 to 60% of patients who are diagnosed with melioidosis. The bacteria can manipulate the host's immune response, causing pathways to escape. This generates a defensive reaction from both the cell-mediated and humoral immune responses. The natural killer cells and adaptive T cells associated with cell-mediated immunity play a major role in controlling the infection. Innate immune response activates the complement pathways. However, the bactericidal activity of the complement membrane attack complex by the external capsula of the bacteria. It is resistant to lysosomal defenses and cationic peptides, which contributes to killing bacteria by destroying the structure of the cell membrane, therefore enabling survival in human serum within phagocytes. CD4 and T cells are important for B cells to switch and activate cytotoxic CD8 and T cells and macrophages. Consistent with this, human survivors of melioidosis display increased levels of CD4 positive and CD8 positive T cells, whereas a decrease in levels of these cells is significantly correlated with greater mortality. The inflammatory response to the infection is to protect bacterial killing mechanisms. Elevated levels of pro-inflammatory cytokines have been observed in patients with melioidosis, some of which have been correlated with fatal outcomes.
Melioidosis is caused by a bacterium called Burkholderia pseudomallii, which is common in tropical climates and found in areas such as Southeast Asia and Northern Australia. Burkholderia pseudomallii is a gram-negative bipolar aerobic motile and rod-shaped bacterium. Gram-negative bacteria have a thin peptidoglycan and outer lipid membrane, which acts as a protective layer against various antibiotics and treatments. They also are more dangerous than the majority of gram-positive bacterium, as the outer lipid membrane acts as a disguise that hides antigens of the cell. This bacterium also has the advantage of being a bacilli. Its sling-like rod shape allows it to move around with ease. The bacterium is identified as a saprophyte, which means it lives on dead or decaying matter. It can be transmitted through inhalation, ingestion, inoculation, or direct entry of the organism into the bloodstream via wounds or skin abrasions from contaminated soil and water. Burkholderia pseudomallii is also known to produce exoenzymes, adhere, colonize, invade, replicate, and survive intracellularly in the host cells. This bacterium is resistant to antibiotics, which makes the prevention of transmission more difficult and less avoidable, especially in areas of heavy rainfall or individuals with health conditions such as diabetes. Current prevention methods consist of wearing correct protective equipment such as waterproof gloves, boots, and outerwear when coming into direct contact with soil and water, ensuring that all skin abrasions are covered and avoiding prolonged exposure to contaminated areas. The guidelines also encourage cessation of smoking and discourage the application of herbal remedies or organic substances to wounds. However, the effectiveness of this advice in reducing the incidence of infection has not been proven.
The diagnosis of melioidosis is often complex due to its non-specific clinical manifestation and misidentification of its associated microorganism, Burkholderia pseudomallii. To diagnose melioidosis, its causative organism, Burkholderia pseudomallii, must first be identified. Laboratory diagnosis begins with the culture of sputum, blood, pus, or other specimen from the likely site of infection. Sputum and pus samples are to be collected into an appropriate transport medium and should be taken to the lab immediately. Blood samples are to be inoculated immediately, placed into blood culture bottles and stored at room temperature, and then incubated at 37 degrees once it's in the laboratory. Culture of Burkholderia pseudomallii from these clinical specimens remains the mainstay of diagnosis, with slow growth on standard blood/McConkey agar media. The typical appearance of Burkholderia pseudomallii on sheep blood agar resembles creamy, non-hemolytic colonies that have a coliform after 2 days of incubation. By day 4, the colonies are covered by a slight metallic sheen and become dry and wrinkled. On McConkey agar, the colonies resemble a colourless, non-lactose fermenting coliform after the 2-day incubation period. By day 4, the colonies will appear dry and wrinkled. However, to provide more of an accurate presentation of the organism, a selective media such as an ash downs agar is used to facilitate detection of colonies. The colonies develop a characteristic appearance of rugose, and they take up crystal violet dye from the medium. The gram stain will present itself as a gram-negative bacillus with bipolar staining that resemble safety pins. Due to the severity of the disease, however, rapid detection is imperative. Thus, direct immunofluorescence microscopy of infected sputum, urine, or pus should be used. It is 98% specific and 70% sensitive compared with culture, but allows a quick confirmation of the diagnosis in less than an hour.
The complexity of the microorganism Burkholderia pseudomallii associated with melioidosis consequently inhibits a fast and effective treatment plan. Due to the inherent resistance conferred by the pathogen Burkholderia pseudomallii to a wide range of antibiotics, the remedial options for treatment of melioidosis are limited. As a result, the treatment of melioidosis becomes prolonged, requiring an intensive phase and an eradication phase. 3 main patterns of antimicrobial chemotherapy are appropriate: initial treatment, subsequent eradication therapy, and post-exposure prophylaxis. Intravenous antibiotic administration is required in the initial intensive phase of treatment. Ceftazidime and meropenem is administered for 10 to 14 days or longer. Ceftazidime is the frontline standard of care and is recommended when treating acute melioidosis, whilst meropenem is a recommendation for severe melioidosis. The course of initial therapy may be extended to 4 or more weeks. This will be determined by the severity of disease, such as septic shock and neurological melioidosis. Subsequently, once improvement of the patient occurs, the eradication phase is vital to reduce the risk of relapse. This is a crucial process to prevent the reactivation of latent cells that can result in septicemic relapse. Reactivation of latent pathogenic cells occurs at an indeterminate time, activated by trauma or immunosuppression. This suggests that Burkholderia pseudomallii has the ability to enter a dormant state to avoid immune surveillance. Oral agents such as trimethoprim, sulfamethoxazole, and co-amoxiclav or doxycycline are essential during the process to control the infection following the initial intravenous treatment. Though these treatments are effective in lessening the symptoms of melioidosis, they do not provide an overall eradication of the disease.